my presentation is complication of craniotomy in TBI. It's a very basic paper. Uh, so we know that DC represent a life-saving procedure and entail removal of a part of cranial bones and open the dura mater. Our aim is to create the space and prevention of the neural tissue damage and herniation. So it is not a new surgery. It was started in ancient Egyptian and Roman time, and but there were high mortality. So very few patients were saved. So it was not continued till 1890 to 90. There was rest, and again looking to the burden of severity of the burden, DC was tried and change in the technique was done because the American guidelines. The technique was changed, it was again started. And we see the change, very good outcome of the patient, very less mortality. So what are the technique? We fix the size of the craniotomy. It is 15 centimeter, which adjusts about the 86 ml of the volume. So there are so many studies are there to know the outcome of DECRA. This is the Cooper study, which from the multi-centric study. There was the 155 patient. The about 73% they were having the DC with standard care and 82 standard care. The patient who was did that surgery had a less ICU time and ICP gone down very fast. But as far as the death rate is concerned, there was more in DC, but there was not much difference, only 18 and 90% or 1% difference. So the complication, if you see in this study, in DC, the complication were more to the surgery related, while in standard care, the complication were like pulmonary embolism, pneumonia, septic shock, they are more related to medical management. So still work hard on it, and rescue trial came. And here, if we see the data, a 6-month follow-up, the death rate was less in surgery, in control is more, but overall the vegetative state was more in this in 6-month follow-up, and after the final outcome, 42% contrast to 34% in the control study. Again, 1 year follow-up was seen study in these patients, and again we found that the surgery was having less death rate compared to control, but overall outcome was better in the surgical group of the cases. So this is another study which shows that in decompressive craniotomy there is higher death rate, about 70%, contrast to 51%. The unfavorable outcome was considered death or persistent vegetative state or severe disability. So they are the different authors. Their experience says that, like Hannibal, that the long-term benefit DC regards as salvage of therapy, long-term deleterious cognitive and psychological effect resulting poor quality of life and economical burden are well known. While as per the Wang, there is a half of the death in DC, but not statistically significant, and ICP in hospital stay is less. And recently, from India, this recent study, that lower mortality, 50% of the patient, poor neurological outcome, it is the observation. So we all know the complications of the DC. This is the Stone syndrome of Triphyte, which was coined by Yamuro and McKenna, by the Schenken-Philip syndrome. Here there is a cognitive function dysfunction, hemiparesis, and hydrocephalus after some time. Hydrocephalus after some time we see in this patient because of flow abnormality, direct atmospheric pressure, and circulation of the blood is less in this, which is reversed by the cranioplasty. So overall the complication, early complication, there are hemorrhage, cerebral herniation, wound complications, CSF leak, post-operative infections, and seizures. Delayed complications are subdural hygroma, post-operative hydrocephalus, automatic, and syndrome of Triphyte. So I will share a few of my patients' complications. They are the subdural hematoma, which was done, DC was done, and patient after so the brain bulging post-operatively. At the 3-month, patient even in the vegetative state. This is the for subdural DC was done, and we lost the patient after post-operatively. This is the subdural hematoma, thick subdural hematoma. DC was done, and we lost the patient after 3 days. This is a patient operated for subdural hematoma, and post-operatively we noticed this hydrocephalus with bulging of the flap. This is another patient showing the DC was done, showing the brain bulging, but this is not much, and patient gradually improved. This is a patient, DC was done. This is the first post-operative day showing the bulging, but post-operative second day showing multiple contusions here. So they are all complication of the GC. So here there is shrunken flap syndrome, but patient had only right hemiparesis, very mild neurological deficit. This is a patient who was operated for subdural. Patient showed this shrunken flap syndrome, early hydrocephalus, and 1 year follow-up. Patient remained unconscious. This is another patient. Craniotomy was done, but post-operative patient improved only in form of eye opening only. Then this is another patient where the patient improved and patient have no neurological deficit. This here patient has a bilateral frontal contusion. This bilateral craniotomy was done, and patient post-operatively developed the hydrocephalus, and which was improved after the cranioplasty. This is a patient subdural hematoma showing the hydrocephalus bulging, and patient improved after the 3D cranioplasty. And so complications are there, but they are reversible also in number of the cases. Here the patient ICP was monitored, subdural hematoma, DC was done, but patient remained in severe vegetative state. ICP remained high even after few days of surgery. So if we see overall the complication, patient should be watched with frequent CT scan. If post-operative epilepsy, we should give anti-epileptic drug. Subdural effusion, craniotomy should be done. If synovial find early cranioplasty is very important. Paradoxical herniation, then post-operative infection, prophylactic antibiotic, and hydrocephalus. What is my experience? We do 2 or 3 DC every day. We have large volume of the head injury patient. So good irrigation, no blood should be left in the wound. This is which is our observation, and the craniotomy flap should be 2.5 to 3 centimeter from the midline. And for chest infection, definitely early tracheostomy is important. So a persistent vegetative state is the most devastating outcome of decompressive craniotomy, but pushed us to think, to reassess what should be done, but there is no other way. If surgery is done, it should be done with the follow-up of the clinical and deterioration before that for better outcome in these patients. Thank you very much.